afternoon, and thank you for joining the Superior Health Quality Alliance Nursing Home Leadership Roundtable event today. Today's topic is our second in the FTAG series, Turning Deficiencies into Efficiencies, and it's F550. I know we did this last week, but we have a new topic to present on this F550 because it's so broad. Residents' rights, resident and family councils, and responding to grievances. My name is Constance Tetrov, and I am a Quality Improvement Advisor with Superior Health Quality Alliance. And I am accompanied by a few of my colleagues. I have Keisha Plesko, Margaret De Oliveira, as well as our guest speakers today, Jane Brink and Maisie Blaine. We host these 1-hour sessions on the second and the fourth Wednesday of the month. The first half is a didactic presentation, then the remaining time will be for Q&A. The PowerPoint presentation link will be dropped into the chat momentarily. Please use the chat box to share any comments, questions, and even resources during the presentation. Besides learning from our speakers, we learn from each other and our peers. Towards the end of today's event, we will also put an evaluation link in the chat that will take only 1 to 2 minutes to complete. We use that information in your evaluations to understand and give a better experience of what you experienced. Today, we have Miss Jane Brink and Miss Maisie Blaine to present on residents' rights. Go ahead and give an introduction. We welcome you.
I'll let Jane lead off.
Okay. Thank you. My name is Jane Brink. I've been a regional ombudsman, and I am currently an ombudsman specialist, which specializes in resident and family council development and education. I've been doing ombudsman work for 37 years, and today I'm going to share my knowledge about resident and family councils. Macy?
Thank you, Jane. Maisie Blaine, Office of Ombudsman for Long-Term Care. I am currently serving in the role of policy specialist for our office. I have also previously served in the role of regional ombudsman for a region in northeastern Minnesota, the Arrowhead region. I've been with the office, gosh, I was trying to think, something like 12 years, I think, this year, since I've come aboard. My background is in mental health county services, and I also worked in a long-term care facility. So both as a nursing assistant through college and a director of social services before I came to the Office of Ombudsman. So happy to be here today. We're actually gonna talk about we're gonna loop rights in to our conversation about councils and grievances as we go through the presentation today. And I think Jane's gonna lead us off with the first few slides.
Great. Okay. So do I have access to, oh, good. You did it. Thank you. We will go to the next slide already. Thank you. My position is I'm going to introduce to you, and we already did really, but the council specialist position is special to the state of Minnesota. I don't know other states that have it. Iowa has something similar, but other states, even our bordering states, I don't know if they have that position with the ombudsman program. We actually have a piece of legislation that was put in the 80s, early 90s, that gave money per bed of skilled nursing home bed to help with the resident and council development. So that's one of the reasons that we have that. We're going to talk about that, and we're going to talk about the council just requirement refresher, discuss common issues and practical approaches, best practices to our partnership with resident and family-led councils, and then also Macy will be talking about grievances in her policy role. And then we have a lot of new tools and resources on our fairly new website that I want to share with you. Next slide. This is our mission of our office. And so we're going to kind of guide our talk through this. Our office is developed to empower, educate, and advocate alongside Minnesotans who are receiving long-term care services and supports to ensure their rights are upheld. So that is part of where we got together and changed our mission about 4 years ago. And so we're gonna go on that line with our education, advocacy, and empowerment. Next slide. I think this is Macy's slide, right? Oh, maybe it's still mine.
Yeah, you're going to do this.
Okay. What is an ombudsman? And we get this from everyone. I just gave a presentation at Leading Age last week, and someone came up and said, I always have such a hard time saying that word. And I told them that from the beginning of time, I learned this from a senior federation, older adult said, just split it up. Ombudsman, and then I could do it. But it's an independent state agency that serves people needing and receiving long-term care. And we do that through our complaint investigation, our advocacy, and our education. The people ask about the history of the word ombudsman. It's a Scandinavian word meaning representative of the people. And in the old country, the king would send out their ombudsman to find out what issues and concerns were out there. They would bring it back to the king, and the king would try to resolve them. So obviously we don't work for the king, but our positions are paid for through the federal and state funds. And so our job is to also share the information that we receive from residents with their consent about issues and concerns that are out there so that we can make changes with the regulations and the statutes and the laws. So we do have a little touch with the history there. We can receive referrals from anywhere. We get a lot of referrals from families, providers, hospitals, residents, friends, neighbors. We need consent from the resident who is involved because the resident is our client. That's why we are there. So there may be times that a daughter will say, hey, mom hates her roommate. Can you go talk to her? Well, and I talked to the resident who is the mother, and she says, oh my goodness, I love Gladys. My daughter doesn't like her daughter and they're fighting. And so she doesn't want us to be roommates. So obviously I would be listening to the resident who has the roommate and not try to separate the roommates. So that's an easy example to tell you, who our client is and who we listen to. Okay. Now, is that your slide, Mace?
That's me. That's me. So an ombudsman's an advocate, as Jane said, that can help residents understand their rights and make sure they know how to exercise them. So in addition to doing that kind of boots on the ground advocacy in care facilities, we also provide information and referral services. Sometimes it might just be in the form of a quick phone call to a resident, a provider, a family member, or someone else. Maybe it's about seeking access to long-term care services and supports, or just a quick question about their rights in a care facility. We work to empower residents, and that has a lot of tie into Jane's role as a resident counsel specialist. We really feel like getting the tools in the hands of residents to be able to empower them to advocate for their rights is the best possible solution. We also really appreciate our champions in the provider world. And I know that's the audience we have here today, making sure that residents have access to the information about their rights so that they can be empowered to stand up for them. We investigate and resolve complaints, but we do that in a different way than the regulatory agency. And so, I used to love when I was a regional ombudsman, I would go out into facilities and I'd pull up in the state car and you'd walk in and you'd have, staff kind of greet you at the door and go, oh, thank goodness it's just you, and so people would get kind of up in arms about maybe the health department or CMS walking in. And I really worked hard to kind of build relationships with the providers in the region that I served so that they knew, yes, I might be there to investigate or resolve a complaint, but we do that for the purpose of resolving it to the satisfaction of the resident, right? We didn't do that for the purpose of giving a citation or having accountability in that regard. So it might be, just making sure they get their medications at the time that they choose, or making sure that they are getting their laundry back from laundry department, or maybe looking at a larger policy and procedure about how we engage residents in the meal planning process for the month or something like that. So just working to investigate and resolve those complaints, always to the satisfaction of the resident for whom we're advocating. And then always we maintain confidentiality in our work. So, if we go out and visit with a resident and the resident says, "Oh, I don't want to do anything about this just yet. Let's just leave it alone." We respect that, and we will maintain that confidentiality. There are other times maybe when residents maybe have a complaint or a concern and they're not quite to the point where they want to bring it up, but they do want to do something. And so we might look at that council avenue, right? Maybe it's short staffing, or maybe it's care concerns on the night shift. And we might be able to utilize kind of this council process to say, hey, are others having a similar complaint, right? Are others having a similar concern? And sometimes people can feel more empowered with those numbers, right? There's power in numbers, and Jane will talk a little bit about that when she talks about council work, but bringing that complaint as a united front, as a council, versus bringing it as an individual can sometimes help residents feel a little more insulated, right, from retaliation or what they might perceive as retaliation, even if that's not happening. So those are among some of the things we do. And then we can go to the next slide quick. This one is just kind of an overview of our office, and I know we have audience members from 3 different states here, but in Minnesota, the Office of Ombudsman has grown tremendously in the last few years, and part of that ties to the passing of our assisted living bill in 2019. We were given a number of FTEs, 17 FTEs, in fact, which brought our staff, I think at that time we maybe had about 17, so it kind of almost immediately doubled the size of our office. We began hiring over the next year, and then have gotten to the point now where in 2024, Jane and I just came from a staff meeting before this presentation, and I think there are 40 of us in total with this entire 44 with this entire office structure. So we currently, I actually think, have a few more than 25 regional ombudsmen. It might be right in the ballpark of 30. We have 3 awesome intake staff who field many of those calls that don't go right to the regional ombudsman. We have the resident and family counsel specialist, Jane, who's on the call today. We have 3 self-advocacy specialists. We actually have 3 policy staff now, myself and 2 others. And then we, of course, have our state ombudsman, our deputy ombudsman, 2 ombudsman supervisors. We have a couple of data staff to support all of our efforts in tracking, some other administrative staff, a website and communications person, and then 1 full-time volunteer coordinator who runs our certified ombudsman volunteer program. Next slide, please. And because Macy didn't follow the instructions, you'll see this is blank, but I'm going to talk a little bit just about what my role is. If anyone wants a copy of a filled in slide deck, I can get that out. I did run it through Accessibility Checker, but because of Superior Health requirements, we weren't able to get it uploaded today. So I do have that, and I'll provide my email. But my role as a policy lead is basically being the lead on interpretation of laws and regulations for the rest of the staff. I help to maintain and develop our internal policies and procedures, work on staff training. We might track systems work across long-term care. Do we have a corporate entity that's growing and we're seeing increasing complaints in a certain category? Or are we seeing, statewide, and I think we're seeing this across the board, but statewide staffing concerns? Are they concentrated to different regions? What kinds of complaints are we seeing? And then what, if any, legislative changes might be needed, or policy changes to address those things? So in terms of empowerment, we work closely with the council specialists, the self-advocacy specialists, on tip sheets that get published to our website that they're bringing out to facilities. We work on prevention materials, and that's in an effort to give them the tools to empower residents to exercise their rights. We've started a government delivery system. So every month this Gov Delivery goes out, and it might be on the topic of restraints, or it might be on the topic of right to decline medication. And so we're really getting that information out to the masses, providers, residents, families, advocates, legislators. We have a really broad array of people that sign up for our Gov Delivery. We also, as Jane mentioned, are just newly in the website world. So it's kind of embarrassing to say out loud, but I think we did not yet have a website. I don't believe in January of 2020. So somewhere in that ballpark, and Jane, correct me if I'm remembering incorrectly, but we just got a website in the last few years. So we're really proud of that. We're really proud of what we've been able to add to that. And it's really been a way for us to be able to empower people to get access to information, but also build on that education piece. So we do community education like this for providers, for staff. We do those Gov deliveries. We try to update the website. And then we do a ton of, in my role as a policy staff, do a ton of education for our regional ombudsman and our certified ombudsman volunteers. And then in terms of advocacy, we're always seeking understanding from people in the long-term care world, right? Residents, families, providers. What are you seeing? What are you struggling with? We're connecting them to a regional ombudsman, a counsel specialist, a self-advocacy specialist. We might connect providers to their provider organization to get support in something they're struggling with. We're attending legislative meetings. We're testifying in hearings. We're building relationships with the Department of Health. I meet with the Department of Health every other week for the skilled nursing health regulation division. My colleague is meeting with our assisted living folks every week. And so really building on, hey, you didn't cite this when you went out. Can you tell us more about that? Or you did cite this, and gosh, we really thought the provider was doing a good job of honoring resident rights. Can you help us understand this a little better? And so just really building those relationships helps us be better advocates to the people who reach out to support us. And we'll go to Jane's slide next. Oh, there you go.
See, there we go. As I said earlier, this position was developed actually in the legislature, and we've had it for over 20 years. So my examples for development are lately, since the pandemic, it seems that the biggest issue is igniting and getting people excited about family councils. So I'm helping facilities develop those family councils. A lot of times, if someone from the Ombudsman program comes to that first family council, we can share a lot of resources and help them along with developing a new family council. Some councils, there's always some silver linings in bad things that happen. Some facilities have now have their family councils online, or a hybrid where some people are at the nursing home and others are online. And that has been very successful. You may have a daughter who's a healthcare agent who lives in California and adores her mom, but has never been able to go to those family councils, and now they can. And so we found a lot of success in that. The next couple of weeks, I'm going to one part of the state where I travel around several nursing homes, and my goal then is to meet with families to help them develop a resident council, family council meeting. So we've really concentrated on that in that development, and then also new igniting that excitement in resident councils. And so visiting the resident councils, sharing our resident council manual and our family council manual that are on our webpage that you can copy off if you want to look at it and use information from it. The residents, they seem to be smaller groups. And so the next 2 weeks, I'm also doing family council kind of encouragement. And one facility came up with it, and they said, why don't we have like a meet and greet and have the dietary do some cookies and coffee and just talk to those residents that aren't coming to the council and tell them what we do. And it's a great idea. And then the regional ombudsman and myself will be there too. So it's just kind of what they do at PTA meetings, to be honest, and getting people excited about participating. And that was something that the residents, a small resident council of 5 people, said, we used to have a lot of people before the pandemic. Maybe we should have a little open house. And so that's how it developed. We always empower the residents and the families to take as much leadership as they are comfortable with. So there are times I have a few resident councils that actually do run by themselves, but you really have to have that group of residents that are comfortable with it. In this particular situation, we happen to have some residents that have, worked for big boards out in the community or public service, and they're really used to those kinds of things. Other times you have a family member from corporate or a resident that was a corporate person that wants to keep their skills going. But for the most part, we have the traditional councils of, a staff person, the designated staff person being involved. But people have done some really creative things as, the residents meet for the first half an hour all by themselves, and then a staff person comes in, starts writing the notes and helping them with their grievances or concerns. Examples of advocacy is providing those action forms, and you'll see those at the end through Macy's presentation. And then education. We educate every time we meet with the residents and family councils. Macy shared our tip sheets, which are also on our website. And we developed them because we have a bunch of volunteers and a bunch of regional ombudsmen that also go visit the councils. And they were noticing that staff would, just kind of read the Bill of Rights, a different section each time. And that is fine. But a lot of times they didn't have an example, and it wasn't very interesting. And the staff felt that too. So we're providing that so that a resident can read it, a volunteer can read it, an ombudsman can read it, or a staff person at the facility, and they can read it and say, this is that you have the right to grievances. And then we always have something on the back that's fun, like a word find, or I'm really into those scavenger hunts to find that person that's the designated person to do this duty in the facility that you live in. So next slide. This is something I'll just tell you because I'm proud of that. We were one of the first states, if not the first state, to have a resident council. It happened in 1972. Three facilities in the Twin Cities got together and said, we need to start councils in our homes, and we need to fight the personal needs allowance and all of our dietary issues. And they met at in their facilities, and then they met as an area-wide council, and they were successful in changing our personal needs allowance, and not just changing it in that year. They changed it to be changed with the cost of living through Social Security. So every time Social Security would have the cost of living, and Macy, you correct me if I'm incorrect on that, they would change. So right now we have our personal needs allowance is $125, and literally there are still states that have a $30 personal needs allowance. So it is a change that group did years ago, and so we're real proud of that we have such a history of resident councils, and we're kind of the leaders in that area. Next slide. This is a quote, and I love this person. And she just talks about where I live, the meat is tough, and we get canned fruit even when it's summer. The vegetables are cooked to a pulp so hard that we can't get a fork in them. The dietary service is so very important to the quality of life, and so poor results that your appetite disappears from unfulfilled anticipation. I mean, talk about visuals and articulate. And that was at that very first resident council meeting. Unfortunately, we can still hear these same complaints. But thankfully, we have alternatives and things like that we've put in over the years. But we still do hear those things. And so it just shows how powerful hearing it from that person that lives in a facility and eats those hard vegetables every day. Next slide. This is an example of when, and you can see how old it is. That's our Governor Rudy Perpich, and he's passed away and gone and done his duty, but there's still some advocates in there that still work in the system. But these are the things they petitioned, they had signs, and the governor, and this is him signing the personal needs allowance. Next slide. When do you think this happened? Well, this is actually that legislation that Macy talked about, where we were able to change our assisted living regulations. So we show this to residents to say, you know what, we're still doing it. And the power of the simple sign saying, I don't deserve abuse and neglect. Please protect me, protect the seniors. You know, those are still things that we can do in 2024 and make a difference. Next slide. I'm not going to go through this. This is just a definition of resident council, and you can see that in the rights. But I think the biggest thing is that we look at the quality of care and quality of life, and they're both important. Next slide. And this is the same with the resident council. The regulations are very similar for the family council. However, with the resident council, the facility needs to provide a designated staff person, and the council needs to vote whether they approve of that person. I want to tell you that when I go around, everybody usually, I've never seen anyone not approve that person. They usually pick the social worker or activities director, but they're all doing that vote either in January for the whole year or at every meeting. And so I was really surprised that they are doing that vote each time, but grateful that they are looking at their rights and knowing that they have that right to who is coming into their council, and that they feel very comfortable with that person. Next slide. These are the rights as far as the regulations. So the facility needs to provide a private space, and that privacy needs to be doors shut. Nobody coming in and giving someone medication. Or a couple months ago, someone came in and started cleaning, and they started vacuuming, and we were having a meeting, and it was a brand new staff person. You know, she wasn't told, she just knew that she had this room to clean. And we just talked to her and just said, you know, privately, and just said, you know, this is an important meeting that, you know, we can't have cleaning at the same time. And then I told the residents and the staff that we need to treat a family and resident council the same as a board meeting. We wouldn't come in if the board of directors were meeting and start cleaning. So just changing that mindset that this is a very important meeting that is in the law. It's not just a best practice. It's in the law that you need to provide this. I talked a little bit about the designated staff person in the resident council needs to be approved. And then the facility needs to consider the views of the council. This is not just when they send an action form or a grievance, this is something they have to review, and then they have to give their answer of what they're going to do and why they made that decision. They need to make reasonable steps for the residents to be aware of the council meetings. We used to, in the olden days, put it in the bill, but now everything is electronic. So send that email out, put the signs around, making sure that residents and families know the council exists, and then respond to the concerns promptly. And Macy's probably going to touch on some of that too. So next slide. This is the federal law, and I chose the federal law to look at, but I kind of went through it already because we also have state law in our state, and since it's only one of you represent Minnesota probably, and I didn't want to touch on that. So I think the biggest thing is that you know, the facilities must respond promptly, and that the council can give recommendations. The facility may not take those recommendations specifically, but they need to really look at that and analyze. And I can explain a little, I'll give you a little example. I had two facilities that were really concerned about call-lights, and they made the recommendation that they wanted all new whole call-light system. One facility said, yes, we totally agree, and started the new call-light system. The other one said, you know what? We would love a new call-light system, but what we're going to do is audit and make sure that there's alternative ways for people to call. And we will not be able to get a new call-light system until next year because it's not in the budget. Both of the councils were satisfied with the answer as long as they were still protecting those residents, that they were able to get action from staff somehow, so that their systems were audited and making sure that that older one was working. But also there's research that shows just being heard is satisfactory, even if you don't get the exact same thing that you want. And so those are two examples of not getting it for one and getting it for the other, but still being satisfied.
And we're gonna actually leave it on this slide, and then I'm gonna supplement some of this information with a few slide decks that aren't in here. So yeah,
awesome.
when we talk about what a facility is required to do, actually FTAG F565 addresses resident and family councils. So the facility staff are required to consider the group views and act upon those grievances. They have to consider the recommendations and attempt to accommodate them to the extent practicable. And then this might include developing policies or changing policies that affect quality care in life. Facilities should discuss decisions with the resident and family group, document in writing its response and rationale. And then that's actually required under 42 CFR 483.10J. And I don't have that citation up on the screen, but like I said, we'll provide our email, and I can plunk these slides out to people who are interested in them. I think it's really important. Jane's example is really good because if you have a solid policy, right, about your timeframes of responding, this is going to really help when the health department does come in, because when they come in, they're going to say, is there a resident and family group? Who are the representatives? Who's the designated staff? And then they're going to conduct interviews with those people. Can the group meet without staff present? Can they have a family member join them? How is this handled? Is there a group vote? What happens? What are the grievances and recommendations? The call-light example was perfect. If it costs $180,000 to put a new call-light system in, that might not be a mechanism for the facility to adopt immediately, right? But if the call lights aren't working, what's the workaround? Did they get people bells? Have they gotten, do they have an ability to call from a phone in their room to the front desk and someone's actually answering the phone? What is that mechanism? If the recommendations are considered, how are they considered? What thought did the facility put into it? Did they bring it to their QA team? How did they respond? If there is non-compliance, right, if there's no record of what you did or how you fixed it, the health department could potentially give a citation. And so you're going to want to make sure you document that well, and having a solid policy is going to help you show the health department what you've done. And so, having that resident log, having that grievance information, making sure that you have a solid process. Now, some facilities will say, hey, we'll get back to an individual in 7 days, and we'll get back to a group in 10 days or 30 days or whatever. So, it might be really, really spelled out in your policy, and it might be more vague, but you're going to want to have a solid policy in that regard. The other issue is individual grievances, right? And so we talk about resident rights, which falls under FTAG 550, and residents have so many rights that are enshrined in both federal and state law, but it doesn't really matter, right, if they don't get to exercise those rights. So on individual grievances, which is covered under 585, the resident has a right to voice those grievances to the facility or any other agency that hears grievances, Office of Ombudsman, Health Department, Office of Mental Health and Developmental Disabilities in our state. And they get to do that without fear of reprisal or discrimination. They have the right, and then the facility has to make prompt efforts to respond to those grievances, just like in the council situation. They have to make information available to a resident on how to file a grievance. And, maybe that's forms on the wall. Maybe that's on a billboard. Maybe that's something that you review at your council meetings, or every month when you have social services check in with the resident, or the case man, or the nurse manager. So you just have to have a grievance policy that talks about how you will promptly resolve grievances for people. And really, the statute does individually define what a prompt response is. So they say very specifically that prompt efforts to resolve include facility acknowledgement of a complaint and grievance, and then actively working toward resolution. So have those really well-defined policies, have them built in. Your grievance policy has to include notifying the resident individually through postings in prominent locations throughout the facility, having it on a message board, having it on a rights board. They also have the right to file grievances orally, right? They don't have to do that in a written fashion. So what does that look like? Who can they go to? Who is your grievance officer? They have to have the right to file grievances anonymously. So you have to have a mechanism. Maybe that's a form on the board and a box that it can be put in after hours, some way. Maybe you slip it under the social worker or the administrator's door. However that happens, you need to communicate that to your residents. Making sure the contact information of the grievance official for whom a grievance can be filed, that their name, their business address, their phone number is listed in those prominent locations, having reasonable expected timeframes for completing their review of the grievance. If health comes in and they start reviewing those, they're going to want to know, what is your timeline? Is it a week? Is it a month? How quickly are you getting back to people? And then they're going to ask for proof of that. So people have a right to obtain a written decision regarding their grievance. So making sure that you're getting back to them, and that can be in a form that makes sense for your facility and the population of people you serve, but it might be adjusted based on the person, right? We want to be person-centered, and we want to really make sure if someone doesn't have access to a computer or the physical capability to utilize a computer, or doesn't have someone to support them to do that, we need to offer that support, or we need to print it out for them in large print. So we just need to make sure that we're giving those opportunities. Making sure the contact information for places like Stratus and the Superior Quality Health Alliance, state survey organizations, the Ombudsman program, Adult Protective Services are all available to people is really important. And then you're going to want to have a really solid process in place for tracking grievances. And this is on the group side, resident and family councils, and on the individual side. Identifying that grievance official is required under federal law. So who is that person? Is it the social worker? Is it the nurse, the director of nursing? Is it the administrator? Having their information there, making sure they're taking the lead on any investigations, making sure they maintain the confidentiality of any information that is made with a grievance if it is confidential, tracking the dates, the summary, the steps to investigate, the summary of the findings and conclusions. And when the quality organization here talks about turning deficiencies into efficiencies, right? This is exactly what they're talking about, because if you have a really solid process in place for how you do this, then it's really easy when a regulator or a family member or an advocate comes in and starts asking questions. Making sure that you're taking any necessary or immediate action to prevent further violation. If the allegation was really egregious, like somebody was rough with me on night shift, making sure that you're following any reporting requirements. But also the federal law requires maintaining evidence demonstrating the result of all grievances for a period of no less than 3 years from the issuance of the decision. So if you have a grievance that's filed on January 2nd, 2024, and you don't get back to them until the 31st of January, you need to keep that information for a full 3 years from January 31st. So just really making sure that you're tracking that. And then I would be remiss if I didn't throw in a little more information about reportable grievances, right? So there's this extra layer of reportable grievances. So any alleged violation involving abuse, neglect, injuries of unknown origin, misappropriation of property, those need to be reported in accordance with state law. And then making sure you're coordinating with the appropriate agencies, whether it's the Department of Health in your state, the Adult Protective Service entity, law enforcement, whomever that is, and then always just taking appropriate corrective action when needed in those situations. And then lastly, I just want to mention there are about 13 distinct federal tags that consider the review of grievances. So 585, which I talked about, is right to participate in resident family groups. 565 is grievances. You've got 550 that is rights and dignity. 803, which is menus and nutritional adequacy. 574, which is right to notices in an understandable language. 847, it's built into arbitration agreements. 602 and 603, freedom from abuse and chemical restraints. Your social service tag, 745. 744, dementia care and treatment. 675, quality of life. 607, abuse prevention plans and policies, and then 586, contact with any external entities. And so these are all just examples, right, of how important it is to have solid abuse prevention plan, policies in place, solid grievance processes, because this can be the ticket, right? To be able to show on all these areas how you're doing a really great job, because being providers is really hard, and caring for people is more complex than it's ever been. And the comorbidities, right? We've got people who are really sick, or people who have co-occurring mental health issues, or complicated family dynamics, and that all comes into your facility. And so you're gonna get complaints, and it might be about care, and it might be about medications, and it might be about curtains, but you're gonna get them. And so having just a really solid process shows how you're protecting rights, how you're honoring people's rights and dignity, and then gives that really solid database, right, for the health department or advocates like myself and Jane to be able to say, oh my gosh, these guys are doing a really good job. So I think we'll kind of keep moving here. We do want to leave some time for questions, but go ahead, Constance, and we'll do the next slide. This is a really awesome form that Jane, and I want to actually give this one to Jane, but this is just an example of one tool that we have in our toolbox that you can steal and borrow from our website. I think it's on our website, right, Jane? Yeah, we might want to unmute. But utilizing something like this is a really awesome tool that myself or the health department or a family member can look at and say, this is exactly what the process looked like. So I'll let Jane cover this.
This is on our website. It's in both the family and resident council manual for sure, and it may be also on its own. So feel free to use it. And I guess I'm not going to go through the whole circle, but it shows, the concern is identified and discussed, like at the council meeting. The council documents the concern. The concerns are given to the grievance officer or administrator or leadership, and then they provide that written response, what can be done, and then resolution for further follow-up. And I think that's one of the biggest things, is having that follow-up after, because sometimes we work on things and it may be a recommendation from the council and it just doesn't work to resolve that. Let's keep following up. And so I see that hear that at council meetings. Old business, is it still going okay with the laundry? Making sure that we continue asking those questions. But yes, feel free to use this and use it at your councils or whatever you need to do. Next slide. This is just our website and has all that information. And I think then we're done after this next slide. So we can have time for questions. That's
Yeah, there's
just more of the information. So
yep,
more of our rights handouts.
Some resources here. Peruse our website. I think is the last slide, maybe our contact information, but I think Jane and I's contact information. These are some trainings we offer for our Minnesota folks. You can find this also on our website or on the PDF, but I believe Jane and I's email is on the last slide. So, or not. Oh, yes, it is.
There it is.
So just if there are, I've got I do have some slides that are omitted from this PDF. I'm happy to send those out individually to folks. We just wanted to make sure if anybody was using a screen reader or something, we didn't interfere with any accessibility issues or their ability to do that. I did at least get one private message asking for that information, so I'll make sure I get that out to that person. But if others want that, please, shoot us an email, get on our website. But yeah, let's pause and make sure that we have time for questions for folks who have them.
Thank you so much. So we did post the website in the chat, so you can access it there. We want to thank you, of course, for presenting. This was very informative, and we have lots of time for questions still. I don't see any in the chat just yet, though.
One of my questions is, when you do work with individuals and you have your resident council, you may have a family council within your facility, and we are working through the grievance process and maybe they have the same complaint, even if it's resolved. How do we continue to wrap our arms around those kind of grievances that may not go away, for lack of a better terminology? And it could be like food or something like that, where we continue to work on it, we bring it out, and it's still not up to what the resident wants or the family member wants. So how do we work through that?
Yeah, Jane, do you want to take this one, or you go ahead and then I'll go? Yep.
Okay. Yeah. One of the things about, you specifically said food, we've seen a lot of success of food councils where it's a special spin-off of the resident council where they meet regularly on food. And it may be just, looking at new menus, it may be bringing recipes from their past that were really successful. And that seems to help because it's a special time to just talk about food. We know that we may have some people that will bring up issues always because it was something that really stuck to them. That may be a time that individual person would be contacted to the regional ombudsman to work on issue that, if it's the same issue and it's just one person, a lot of times we'll refer them to the regional ombudsman because it may be other issues that are behind that concern that we haven't really investigated yet, and the regional ombudsman can work with that individual. If it's if it's a whole council, then we may do a subcommittee, and it may be, that food committee, or it may be a committee that works on call light systems and that type of thing, and just meets with the administration about, maybe there's a staffing issue and they need more people at a certain time of day because that's when everybody's done eating and they need to use the restroom. So, really keeping that going, and Mace, I'll open it up to you because you probably have some great ideas.
Yeah, those are all really tremendous. I think really building it, bringing it back to those councils, building on that. But I also want to call attention to, what you're talking about. And I missed your name, the gal who asked the question, but what you're talking about are our frequent flyers, right? And so these are the people that kind of always have this revolving concern or worry. And sometimes it's the same thing and sometimes it's a different thing. But these are the folks that are going to talk to your health departments when they come in. These are the folks that are going to flock to your ombudsman when they come in, right? And so really making sure for those folks, for everybody, but for those folks in particular, having a solid record of what you've done and how you've intervened, but also that olive branch, right? Reaching out. If the council avenues, if the food committees aren't doing the trick, having the resident and the daughter have 2 meals a month where they help the dietitian and the food support folks create the ingredient list and the menu items, and they're building that. Maybe it's something from their culture. Maybe it's something, maybe they want taco salads and they haven't had a taco salad in 5 years. These can feel like really big tasks, but they're not hard, right? You get 15 minutes or a couple email exchanges to get the ingredient list and the recipe, and you can kind of start to build trust. Wait, they're doing something I asked for. And maybe it's not everything, maybe you don't get taco salads every day, but you get one taco salad, or maybe you get 2 in a month. And so really building on that. And I think the other things too is just communication, having realistic expectations. If it's, I had one that was the dirty curtains, and it was constantly like, they're not cleaning the curtains. So then, the facility got the curtains taken down and they got them on a monthly washing schedule. So the curtains are getting washed. Well, now the curtains are ratty because they're getting washed, right? And so the ultimate resolve was that they just wanted new curtains, right? They wanted new curtains for the room. And it took a lot of peeling back layers to figure that out. And so it's like, okay, can the facility provide that, right? Or is that something that the facility is maybe not in a financial position to do? But if the family wants to provide that, and you can talk about, well, do they have to be fire retardant curtains? Are there rules about what you can work together to figure out, how that looks if this is the person's home and they want to continue to make it their home. So really peeling back the layers. I think we get these situations where a resident or a family member, have a complaint. Let's say maybe it's taco salads, right? And the fact of the matter is, it has nothing to do with taco salads at all. It has to do with the fact that, they aren't in touch with their roots or their heritage, or their family's not coming to visit. And so I think also just really doing a good job of peeling back those layers on what is the root cause of this. It might not be the food issue at the surface level, or it might not be, the fact that Christy on the night shift was a little snippy on Tuesday evening. Maybe it's that they just got news that their granddaughter in Colorado had a baby and nobody sent them a dang picture yet, So I think really just communicating with folks too. Sometimes what they're bringing to the surface isn't really the main issue at all. So I that's just a consideration that I think should be made. But documentation, all the things Jane said, resources, building in those council options, and getting other people involved too. Other questions? That was a great one.
I have a question, and maybe I missed this, but is this program in every state?
Ooh, that might be a Constance question.
So, yep,
Superior Health.
You're required to have resident council in every state. It is a federal regulation for nursing homes. Their specific program may not be in the same fashion, but ombudsmen are in every state, in every region, and they usually have a hierarchy of those ombudsmen, somebody supervising them, a regional director. I don't know if Wisconsin or Michigan has the federal or the funding per bed. I'm not exactly sure about that. I don't think so. Just from my experience, I don't think so, but we can check into that and get information out to you guys.
And
it's also, oops, I'm sorry.
Oh, I interpreted that a different way. So I did sorry. Too.
It is in every ombudsman's job description to work with resident and family councils. So if you don't have a special person in your state, your regional ombudsman would be the person that you would call, and they can do education and they can meet with your councils, and they do. And if you have volunteers, sometimes they're assigned to a council. Macy, I'm sorry, we kept on talking over each other.
That's okay. I was thinking they were talking about the quality assurance meetings. So I do apologize. And yes, ombudsman's programs are in every state. They're federally required.
So I realize the ombudsman is in every state, but let's say a facility wants to have or implement let's say, like you talked about the food council, right? and there's not one in their facility. How would a resident or a person go about starting something like that?
Jane,
They
you're
would
up.
start, yeah, they would start it with at the resident council meeting, and they would vote on, yes, we want a food committee. I have a resident council manual in our website, and you could grab that, and it talks about, developing subcommittees. You could go to your your ombudsman website in Wisconsin or Michigan and find out if they have the same type of manual, which I think they do. And then they could give you some ideas on how to start it. So it would be up to the residents wanting that council, that extra subcommittee, and they have them all the time. Recently, I've been hearing about welcoming committees, that when people come in, they don't know what's going on, because it's a stressful time to sign all those papers. So then the resident council will have a group that go and welcome the new resident. And then now I'm seeing families now connect up with the new families. So it would be part of that resident council meeting.
And that
And
doesn't,
if you want to, the dietary person could bring that up and say, would you like to have that council meeting? I'd like to propose that too. I don't know if that's what you were going to say.
yeah, that's the exact piece I was going to add, is that it doesn't have to be that the residents thought of it on their own, right? But if you're the administrator or you're the social worker or you're the dietary person and you say, hey, could I come to your meeting next month? I had an idea I wanted to present about something related to your dietary concerns. Then you go to the meeting with their permission and say, hey, we heard about, some facilities are doing these food councils. Would anybody be interested in and if the whole group raises their hands, then maybe you just address it as a part of the resident council, and maybe you build in some extra meetings to hash it out. But yeah, it doesn't have to be their idea. The goal is just that they have the control, right? That they're able to make the decisions and decide the direction, but you guys bringing it to the table, not a problem at all. And it would be welcomed, because they won't know about it if they're not hearing about it from someone. Great question.
Mm-hmm. I know we had a question about where the recordings of these nursing home leadership roundtables are. I'm getting the information for that, and I will have it by the next week, just so you know. And it looks like they could also, so if a facility is having trouble starting a resident council, or they don't have one set up yet, they could contact their ombudsman to help them set that up, right? And to know how to facilitate it and how to invite people and whatnot, right? They could work with the ombudsman to do that.
They sure could, and they also could and I can't speak for all the other states, but we do have a national local ombudsman, and so I do know some of them in that area, and they do that work. But also, I want to give you the Consumer Voice website, and that they have a lot of resources on resident and family council too, and they have a lot of manuals throughout the state. So they would be a very good source for you to also work on that. But having that ombudsman come for the first meeting is really helpful. Number one, it helps you know who that individual advocate is, but they should have also ideas for the resident council development.
And
in
I
the state
did,
of Minnesota, you can call one of us. So.
yeah, and I did just put the Consumer Voice website in the chat there, so folks can have that. There, I don't know a whole lot about the landscape like in Wisconsin and Michigan, which I think are the other two states on this group, but we are very aware that not every state has as robust a ombudsman program as Minnesota is fortunate enough to have. And so, yeah, if you're in a situation where you were to call your ombudsman at your state level or your regional level and they say, oh gosh, we can't do that, we're swamped, this would be a good alternative. I might still funnel that call up to the state ombudsman to make sure that you're getting what you're supposed to be getting in terms of advocacy, but the consumer Voice website is a really great resource, like Jane said. So a social worker, an administrator, a DON can go on there. The materials are free, available to everyone. They have videos, they have printouts. I couldn't even list them all off in the time we have. So
thank you so much. We appreciate that. Thank you, Jane and Maisie. This is an amazing presentation. I love this topic, of course. We have one last thing that before we conclude, I wanted to tell you about our next presentation, which we're super excited about. Please join us for our introductory webinar on February 28th from 1 to 2 p.m. Eastern Standard Time. This special presentation is Superior Health Quality Alliance has partnered with Vivint Health, a nurse-led behavior change company, to provide an innovative virtual learning program to complement our current infection prevention practices. The program is called Interactive Combined Vaccination Program and has been designed to increase vaccination rates and awareness of the COVID-19, pneumonia, RSV, and influenza vaccines. Unlike traditional and passive education, the material in the program is presented in a fun and interactive online experience. The best part, the program is completely free to you. You can use the link that's going to be listed in the chat to sign up. I believe it's right here. And we want to get lots of information out to you about it. We've tried out the program and it works amazing. So we look forward to seeing you. If you don't mind taking a moment to fill out the event evaluation, we use that information and feedback to improve our services. Thank you so much. Have a great day. And we look forward to seeing you on 2/28.